did make it. We did make a declaration as a state of emergency for healthcare services for First Nations in the North. So we're busy at this point in time with a lot of things like media, etc. So the core the core work that I do, not as a family physician, but rather as kind of an advocate, I would say, is really to center a large argument to change civility in general in Manitoba and Canada, but particularly in northern Manitoba. We have lots of evidence of the ongoing impact of Indigenous specific racism in healthcare systems and services. And we've done a lot of work analyzing data that looked at stereotypes to harm, stereotypes to death, etc. I think it's really kind of core for this particular gathering you have. If you can't contextualize the patient or group or the person or persons with whom you're working, none of our medical systems or sciences actually work. Okay, it's an essential feature of the healthcare system here in Manitoba, from our evidence that Indigenous people are manifested through that system by stereotypes only. So I'm going to give you just a quick argument about why this is important to understand, and importantly, how you as a provider or as an advocate, or if you're non-Indigenous, how the hard drive within you has actually been coached into seeing Indigenous people in stereotype only, and that has very material impacts on the kind of resources you provide, on the kind of clinical services you provide to First Nations people. So while it seems we've been talking about racism for a long time, we're only now coming to understand it as it embeds itself in all healthcare systems, and including the providers. So just a quick overview like that. So we go to the next slide, please. So it's the R word, right? It's, like F-U-C dot, right? So not but 10 years ago, when I would do this particular talk internationally as well as nationally here in Canada, the room would go silent and all you could hear are crickets. And then what evolved from there was that understanding the dynamic between the original peoples to these lands and the settlers. And kind of what it is that occurs between these two groups when we say racism, and what is the intention of saying racism, etc. So we had to work through all of that. We still work through all of that at the larger structures that I work at this point in time. But understanding racism, Indigenous specific racism, is essential knowledge and an essential skill to maintain as you move forward in the work that you do. And if you don't do that, then you're actually moving forward in a blind way. Can we go to the next slide, please? I want to really, some of the work that we did previously in type 2 diabetes as well as chronic kidney disease with our colleagues here, we realized that when we looked at the high rates of chronic kidney disease in First Nations people, and one of our more recent studies showed that there's about a 33% risk factor for chronic kidney disease in First Nations people from about, I think it's from about childhood to adulthood. I can't remember the exact dates. It was 85 and 80. About 1 in 3 people were already at risk for chronic kidney disease. And the only way that we could understand that epidemiologically or etiologically, like what is its source, was to realize that First Nations women at the moment of conception, sperm, ova, you have 1 cell human, then 2 cell, that at that stage we realized that the impact of racism and oppression and stress on Indigenous women who conceive at the moment actually translates into a risk of kidney disease even before the child has left his mother. And that's the only way that we can explain the current stats around chronic disease. So this is actually important because if you think about the chronic diseases that arise because the mother is already in acute and chronic stress, you have to think about STBBIs and HIV. And one of the analytical frameworks we use around that, and I've not written a lot about that, is that HIV and STBBIs are colonially constructed diseases that affect First Nations people. And it's really important that you understand that concept, move away from individuality and look at kind of collective things that affect this particular racial group. So you see high rates of HIV, you see late presentations, etc. We see this in cancer, we see this in heart disease, we see this in diabetes, we see it all over. So that the part of the generation of what a disease looks like in a human is always contextualized into how they're treated, whether they have adverse childhood experiences, all those kinds of things. So it's really important. And I think the work we've been trying to do is to take the biomedical out of constructing the whole concept of what HIV or STBBI or type 2 diabetes is, particularly, or mental unwellness, suicidality. I think you get where I'm coming from here. But what I really wanted to talk about was a little bit of this concept of self-efficacy as an individual. We did work with type 2 diabetics for a number of years, and we were evaluated across Canada with 7 other such projects, like the Diabetes Integration Project that I was with for about 14 years. And there were 3 areas that we did the best in Canada with our work here. Number 1 is we got blood pressure down. Number 2, people stopped smoking. And number 3, people lost weight. And this was done by nurses, not PhDs, not masters, not doctors. This was done by nurses engaging in a positive therapeutic relationship that attended to the need to try and want to stereotype people, okay? And so when the therapeutic encounter that you have with a First Nations person is solid, it is trauma-informed, it is First Nations centered, then self-efficacy improves for the patient. So people can say, okay, maybe I will stop smoking, maybe I will take this pill. Yeah, okay, that's reasonable. So that the important contact, the therapeutic encounter, we believe is really vital to ensuring that you have a trauma, racism-free and centered dialogue in order to influence people about taking a med, influence people about self-care, all of those kinds of things, and including attending to harm reduction interventions as necessary. Now, just quickly, for those of you who are not aware, we studied about 30,000 episodes of encounters in BC. And one of the questions that was asked was about stereotyping. And so it was within there that we, one of the students I worked with is a doctorate now, we studied stereotyping. So essentially Indigenous people who are recognized as Indigenous people going into the healthcare system are only seen in stereotype. So the number 1 stereotype is alcoholism. We're all alcoholics. Mothers are not good. Dads are bad, evil people. We don't care about our health. We're mean, we're angry, all of those kinds of things. And stereotypes function as a proxy for how racism is observed in healthcare systems. And we actually teach each other as providers how to be racist through coaching. And we just published a chapter called White Benevolence. It's out of University of Saskatchewan. On understanding what is that mechanism about coaching. And it's functionally very, very important. And importantly, I know I only got a few minutes, importantly, what is the intervention is really when we hold each other accountable. If you hear me saying something that appears homophobic, then you have to ask me to clarify that. If you hear something that I appear misogynist, you have to ask me. If I, as a physician, for example, think that Mrs. Beardy from Island Lake is only here for morphine for her belly pain, and I tell you that as a student, you have to actually challenge me and ask me to explain that further. Racism is very difficult to work with. We do it legally, but when we have practices of trauma-informed practices and practices that want to go into the intersectionality of how we oppress people, then we need to support each other. And that's really some of the work that we're doing with a grant that I have, working on a curriculum with providers and examining whether or not there's any attitudinal changes and or behavioral changes in clinical services. And so that was all kind of set back by the pandemic we had to take care of. The next one, please. And it's very, very short. Most of the time I'll do like a half an hour, 45 minutes. I have this kind of expanded story, but that's kind of where I'm at. The real focus here is that the community of First Nations people are accosted by racism every moment and for 150 years now. And it's had dire consequences in our ability to take medicines for HIV, dire consequences on a whole number of things, as well as suicidality and other violence in our communities. And that's really, that's not all First Nations people. I'm talking as a scientist that I am about specifically the impact of white colonialism on Indigenous peoples. I just give you a bit of a flair of that. But that's it. Thank you so much.
Thank you, Dr. Lavallee. That was a wonderful presentation. We do have a couple of minutes to spare. If someone out there has a question, you want to just stick your hand up and Cherie or somebody will be monitoring that and we can ask a question.
Right. So Albert, go ahead. You have your hand up.
Yeah, part of me wants to take a look at this work, and not just from a social dynamic, but from a geographic ecosystem perspective as well. And just noting that Saskatchewan, Manitoba have higher rates of HIV and syphilis and other, illnesses, but the proximity to the Hudson's Bay and York factory and the exposure to colonialism much longer than other people in other parts of North America, and the loss of culture, the loss of control through that colonial period is much more extensive among people who are closer to York factory. And you can even make a 1,000-mile radius, and you will see that, the drum just came back to the pot area in the 1970s. No one had hand drums. And that's the extent of that erasure. And people don't understand that. They don't have that mechanism to examine the past. It's all normalized. It's all white noise, background, and it looks normal, but it's highly unnormal.
Yeah, absolutely. Albert, one of the things that we observe is that when we talk historical about colonization, certainly there are consequences. It laid the foundation for what we see today, including residential schools, 60 scoop, now kids imprisoned in the Child and Family Services system only for being poor, okay? Brown and poor, right? And so with Johnny MacDonald declaring that we want the Indian out of the child, the fallout from such a statement by the first colonist government on our lands still has effects today in the universities, the colleges, everywhere. Indigenous people can go to university. When I went to medical school, I understand what residential school is. That's how awful it was being in medical school, and I hated it. And I never went to my graduation. I gave them the middle finger and said, get out of here, and I left. And that was basically it, because that for me was colonization, because I was torn apart inside and out just for being there. So colonization still exists. So when people who are not Indigenous say, can you just forget it? It's hard to forget it when it's in your face every day, every day, every day, every day. And so it's alive, it's doing what it's supposed to do. And it certainly is a cause for excess mortality and morbidity in our communities. Thanks.
I guess, can we take another question?
Yeah. There's another McLeod, and it's not Albert. Oh. There we go. Perfect.
Hello, I'm Carlene McLeod from up north in Treaty 5 territory. I just have a question, kind of. When we look at learning, especially as a healthcare provider, we often see for different diseases, infections, that being Indigenous is a risk factor. Can we talk a little bit of the harm having that being labeled as a risk factor, sometimes healthcare providers fall back on it as an excuse to accept that state of health, I guess, and the negative impacts on the health outcomes of people when we fall back on labeling a whole group of people being at risk of a disease when there is like social determinants of health and poverty, oppression. We know our systems, institutions, like healthcare systems, law, they weren't built with Indigenous people in mind. They had separate institutions for us historically. So just to talk a little bit about labeling Indigenous as a risk factor when it's not.
Yeah, no, that's a really, really great comment and question, and I think you've answered it for us. But I study the mechanisms of racism. I study why is it necessary to perpetuate racism? What are the dynamics between Canada and Indigenous peoples on our stolen lands? Okay, so when you do that, what you uncover is that something called othering, and Shireen Razak uses that terminology, othering. So the person in power turns they don't turn inward, they turn to the person who's being oppressed, and they throw on things on that are not true. And medicine and nursing and sciences are just as biased as anybody else to utilize stereotypes. You see, stereotypes, when used in situations of power, like a healthcare system, I'm the doctor, I tell you what to do, I'm the nurse, I tell you what to do, all that kind of stuff. There is a dynamic of power differential, but it should be used therapeutically and ethically, okay, to influence people's behaviors. But in this case, the settler, mostly the settler provider, will use it intentionally or unintentionally in order to inflict violence. What you're talking about is violence, because it has dire consequences on whether a type 2 diabetic will be given insulin at that moment. Or do I think that Mrs. Beardy is just big and lazy and don't even bother giving her anything? These are dire consequences that kill. So this is very serious stuff. And that's some of the work that we're going to do in Northern Health Region. We have a grant for about $4 to $5 million that we're starting that process now to work with that organization to address racism within the clinical environment. But thanks for that.
Thank you. I think we have time for one more.
Right. So John, if you want to ask your question.
Hi, Barry. It's good to see you. I really have a comment for Carly and a question for you, Barry. Carly, to your question, and it speaks to the track surveillance studies, and full disclosure, because I am part of that system. If you remember the track surveillance studies, there was I-track, M-track, and I-track stands for injection drug users. M-track was for men having sex with men. The A-track that Albert referred to actually stood for Aboriginal track. That was the track surveillance and survey. What that says, however, is, to your point, Carly, that being Aboriginal is a risk factor. It is not. And to Barry's point, what we're seeing is the response or the outcome of the colonial ideology towards what has happened since Columbus stepped on this side of the pond. So your point is well taken, but we still continue and need to learn from that. So thanks very much for that. Barry, my question to you is, you were front and center in the COVID response, especially up north. Did you see the same old, or was there something good that came out of that? Did it get better as a result of COVID?
Yes, momentarily, and no. So our job during the pandemic, because we were on the First Nations Pandemic Coordination Response Team, that was one of the leads from the north, we had to maneuver the largest ship in Manitoba called the Government of Canada and its racist policies and actions in order to save lives. And that's what we had to do. There was Marsha, myself, a few of our other people, SCO. We stood there, we had to meet before and after. We had to do strategies, we had to do science, everything to get this system to go up north, to give us the testing to allow us to do the testing, give us the needles, we'll do the needles. We did all of that. And in fact, at one point in time, I was going to go international and find vaccines because the system is so slow and racist. But that was the work we did. Now, I thought at the end that our engagement with the higher level bureaucrats and the politicians would change systems, but sadly it hasn't. It's just already fallen back into the way it is. So that the work I'm doing now, looking at system changes, that's why we did the release, and we're doing to get these governments to give us the money. If you don't want to do it, just give us the resources. We Indians and half-breeds are very smart people. We're doctors, we're scientists, we're administrators. Just give it to us. So we're looking at abolition, right? It's abolitionists. So working with partners is okay, but it really doesn't change much, because like the Borg, you go back into your wall and you're reinstalled with all the same hard drive, unless you're in an environment continuous gentle confrontation, self-reflection, practicing new ways of talking to women, to people who are gay, to people who are Indian, to people who are Black. You have to be able to do that. That's part of the science and the research that I'm doing currently, but it's not looking that great, okay? So we're looking at abolitionist ways, and so that's why we want to take over our own systems. And we'll hire you, but with different expectations, okay, about how you will actually work with us in our systems. There'll be very different expectations relative to our community people. But that's a great question. Now, the one thing about labeling Indigenous people, there's also the concept of deficit thinking, racial deficit thinking, so that non-Indigenous people can look at me and say, oh, Barry, I did lose my leg. Don't feel sorry for me, it was traumatic, I'm okay. But they look at me and say, oh, he's an Indian who's a diabetic, clearly didn't take care of his diabetes. That's all bullshit. I'm very good at taking care of my diabetes, very good, okay? But it's easier for someone to think of an Indian in deficit. You're never fully human. And Razak speaks about that. She speaks about spatiality, not only a cognitive, but a physical spatiality, that in that spatiality is the frontier of Canada from 1860, where there were no police, there were no doctors, you could murder Indians and get away with it. And so the spatiality of frontierism is what kills us. And medicine and nursing participate in there. From that one question the young girl gave me, why don't worry about their diabetes, they don't care about themselves. That is called spatiality of oppression for Indigenous peoples. And Shireen Razak is actually a good author to fall back on and looking at some of the detailed work she did analyzing deaths in custody. And we did the same thing with Brian Sinclair. Thanks.
All right. Thank you very much, Dr. Lavallee, and thanks for all the questions, everyone.